Good morning, everyone. Welcome to the National Hispanic Council on Aging's Health Equity webinar. My name is Oscar Ramirez. I'm co-founder of Fulcrum Public Affairs. It's my pleasure to moderate today's virtual event, which is supported by the following sponsors: Amgen, Compassion and Choices, Merck, Novo Nordisk, and so thank you all for your support. Over 50 years, NHCOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. NHCOA's commitment to their mission has only been emboldened in the face of the ongoing health disparities in our communities. NHCOA's Legislative Breakfast is an opportunity to open a dialogue between legislators and their constituents, enabling citizens to share their stories and experiences while directly discussing legislative priorities with the lawmakers who represent them. Today's Legislative Breakfast will feature a panel of experts and voices from the field to discuss issues pertaining to the barriers that prevent Latinos from accessing healthcare. Some of the topics we will address include barriers to accessing prescription drugs and the hurdles Latinos face trying to access insurance, obesity treatments, Alzheimer's care, and adult vaccination. After this event, we will come up with a list of recommendations focused on Latinos for lawmakers to address this legislative session. As many of you know, May is Older Americans Month. It is a time for us to acknowledge the contributions and achievements of older Americans and strengthen our commitment to honoring our older citizens. In honor of Older Americans Month, today's virtual legislative breakfast provides an open space to discuss important key issues impacting the health and wellness of Latinos and come up with potential recommendations to address these issues in order for Latino seniors to age in the best possible health. To begin the virtual event, it is my pleasure to introduce my old friend, Dr. Yanira Cruz, President and CEO of NHCOA for diverse older adults. She has been recognized for her commitment and leadership on behalf of diverse older adults nationwide. Welcome, Dr. Cruz.
Thank you. Thank you so much, Oscar, for joining us today. And welcome everyone to NHCOA's Legislative Breakfast. I'd like to take a minute to thank our speakers who are joining us today, our attendees for connecting with us this morning, and thank you to our sponsors for supporting our work. I also want to recognize the Senate Committee on Aging for joining us today. I know you're connected and you were one of the first to respond to attend. So thank you for being there. The purpose of today's legislative breakfast, which is focused on older adults and caregiver issues, is to have an opportunity to communicate areas needing attention from our U.S. legislators. We hope that during today's deliberations, we will express key areas that need attention in order to improve the lives of older adults and their caregivers. Allow me to begin the conversation by noting that first, Alzheimer's disease is increasing at a fast rate. New medicines are being developed and we must make them available as widely as possible. And we call on CMS to act expeditiously to make medicines available that have been approved by the FDA. Second, obesity is on the rise for many in our country, especially Latinos. There are anti-obesity medications available, and we need to make those medicines available to everyone. And thirdly, COVID-19 is not over. Many continue to die each day. We must ensure everyone gets vaccinated and has easy access to pneumococcal and influenza vaccines, as well as COVID-19 vaccines. So the National Hispanic Council on Aging, in conjunction with the National Minority Equality Forum, conducted a national poll. And findings from this poll show that nearly half of voters of color responded that they experienced barriers to care, such as needing approval from their insurance or high out-of-pocket costs. And 4 in 5 voters of color agreed that the pandemic has made them believe that ensuring continued research and development is essential to innovative treatments and medicines. And so We urge you to consider your most vulnerable populations and the effects of detrimental healthcare policies. We must continue to advocate for lowering the cost of healthcare, reducing healthcare access disparities, and ensuring U.S. research and development. So we thank you for your time in acknowledging these issues and appreciate your commitment to older adults and the American people. Thank you, and please enjoy the rest of the session. I turn it over to you, Oscar. Thank you.
Thank you, Dr. Cruz. Now let's welcome our next speaker, Robert Blancato, a board member at NHCOA, and recognized as a national advocate with policy expertise on behalf of older adults. Today, Mr. Blancato will provide welcoming remarks. Welcome, Mr. Blancato.
Thank you very much, Oscar. And I think there's some slides we have here. We can go to the second slide, actually. So thank you for the introduction, Oscar. Thank you. It's an honor to be invited to give opening remarks. I'm proud to be on this board, and I salute Jorge and all my board colleagues, but a special tribute to our leader and ongoing inspiration, Dr. Yanira Cruz. Her effectiveness, her impact grows with time. And also I want to thank Christine Perez for all her work in getting this event organized. Next slide. So as Oscar mentioned, May is Older Americans Month. It is time for us to salute and appreciate our older adults. Aging Unbound is the term that the theme of the Administration for Community Living, but it's also a time to redouble our efforts to help those most vulnerable, which too often includes older Hispanic and Latino older adults. That has always been the focus of NHCOA, and today is no exception. Focus of mine this morning is the impact of the end of the public health emergency in just 9 days. And the emergency existed for a very clear reason, to address a range of issues and new realities caused by the pandemic. Next slide. The realities of the past 3 years, high among these realities was a growth in food insecurity. In 2021, almost 34 million people, including 10.6 million Hispanics, experienced food insecurity. Food insecurity is a precursor to malnutrition, and deaths from malnutrition have more than doubled from 2018 to 2022, according to the CDC. NHCOA is a member of our Defeat Malnutrition Today coalition, and our concern is addressing the 1 in 2 older adults who have or are at risk of having malnutrition. Next slide. So the public health emergency does end on May 11th. It's already being felt in the biggest safety net program that combats food insecurity, the SNAP program. During the pandemic, emergency relief increased SNAP benefits. The number of people in the first 3 months of the pandemic served by SNAP grew by more than 6 million. But the last of these emergency pandemic allotments ended on March 1st. We've seen an average household decline of $90 a month, but more severe with older adults, as most qualify for the minimum benefit, which means their monthly SNAP benefit goes from $250 a month to $23 a month. This could be fixed in the upcoming Farm Bill, but as many people know, SNAP is a target for cuts, and we must work to prevent further cuts. Next slide. So the other issue, the end of the public health emergency, means the end of free COVID tests. We appreciate that COVID vaccines and all vaccines are still free for older adults, but it's just as important to keep tests free. Because recent federal government guidance is saying older adults and those with compromised immunity should get a 4th booster COVID shot. But the overall issue, as Dr. Cruz mentioned, of vaccine access is something where NHCOA has been a leader for many years. And I know this because one of the groups I'm involved with, NANASP, is also very involved in this. Next slide. Particularly in the pneumonia vaccine area, we are trying to make sure that older adults have access to the most current vaccines for pneumonia. Hispanic older adults have lower pneumococcal vaccination rates than non-Hispanics. Our collective fight was to change a misguided policy that would only allow those who had never received a pneumonia vaccine before to get access to new and improved ones. For those who did the right thing and got a vaccine, they should not be penalized. Plus, it could have been years before since they got their first one. They need the newer ones. And working with NHCOA, we advocated for the CDC to change their position, which they did in October, saying that all older adults could get access to these new vaccines using the shared decision-making process. But we're also pleased to hear that Centers for Medicare and Medicaid Services in March revised their policies and have told providers that all new pneumococcal vaccines given from October forward are fully covered by Part B. We need to be ready for the next flu and pneumonia season. Vaccines are being improved. They should be available for everyone. Next slide. So we're moving into a very important time of the year in Washington, D.C., appropriations. And NHCOA will continue to be the strong voice we have grown accustomed to. And that voice is going to be needed to prevent massive spending cuts, as proposed in last week's House-passed debt ceiling bill, to prevent cuts in SNAP benefits and discriminatory new work requirements. We need to work to prevent 15 million people from losing Medicaid coverage, half of whom are Hispanic or Black, and to ensure that telehealth and telemedicine coverage under Medicare can be maintained to the maximum extent possible. And then my last slide just talks about something we're all involved in, which is advocacy. And advocacy is about being ready, reliable, and relentless. So we need to keep the voice strong at the national and grassroots level, as NHCOA does so well. It is understanding who you represent and what their needs are. It's being the resource that NHCOA is to elected officials in Washington and at the state and local level. So please, show your support for NHCOA. There is no greater time to respond than now. Thank you very much, Oscar and Dr. Cruz.
Thank you, Mr. Blancato. And before starting the panel session, for the attendees here today, we want to know your opinion. You should see a poll, there we go. You should see a poll question on your screen shortly. Our first poll question is, what are your biggest challenges to access prescription drugs? We'll provide a minute or so for you to choose. Please note you can write other options in the chat box as well. Okay, I think everyone's had a minute to answer your questions. And I'm not sure if we are able to see the poll results here. There we go. Again, the question is, what are your biggest challenges to access prescription drugs? And it looks like, actually by a pretty wide margin, high out-of-pocket cost was the first answer, and then lack of health insurance. So thank you for that. And that actually goes to this next point. So currently, over half of the US population has a chronic disease, and 86% of healthcare costs are attributed to chronic disease. It's important to mention that vulnerable populations, such as seniors, continue to be impacted by healthcare inequity, which the pandemic has exacerbated and made harder to ignore. In a recent poll conducted by NHCOA and the National Minority Equality Forum, most voters, including voters of color, immigrants, and people with chronic conditions, agreed the pandemic has made them worried about their families' access to health care. Also, most of the voters of color expressed that the pandemic has made them realize that issues of systematic racism and health disparities need to be addressed. Our first speaker this morning is Ms. Amy Hinijosa, President and CEO of MANA, a national Latina organization, the oldest and largest Latina membership organization in the United States. MANA has been the leading voice for Latinas in the areas of health, financial well-being, education, and technology access, environmental concerns, civil rights, and diversity and inclusion. Today, Ms. Hinijosa will address affordability issues impacting chronic disease patients in the United States. Welcome, Ms. Hinijosa.
Thank you so much, Oscar, and thank you to Dr. Cruz and Christine from NHCOA for the invitation to speak today. MANA, in being a voice for all Latinas across the United States, we know that healthcare is top of mind for all of us, particularly as we come out of the pandemic, and particularly in the wake of all the impacts that we saw for our community in the wake of the pandemic. And so the part that I want to talk about is the affordability. You know, in the poll that we just saw, affordability really is top of mind for everyone. I think it was 62% of you just listening in on this conversation refer to cost as being the primary factor in keeping folks from their prescriptions. And so there are two things in terms of policy and legislation that we at MANA are working on in concert with many of our coalitions. You know, we can't do this work alone, and all of our voices, you know, when we come together to work in coalition, the rising tide lifts all boats. So we work in concert with the Health Equity Collaborative, which is a group of 50 national organizations that are Latino, African American, women's groups, LGBT groups, disability groups, industry groups that come together to make sure that we're coming with one clear voice to talk about the issues related to health equity and keep those top of mind for our policymakers. We also work with the Health Equity Coalition on Chronic Diseases, and specifically focused on access to obesity care and medication. We also work with RDDC, the Rare Disease and Diversity Coalition. And again, the idea here is to say, look, where does a Latina voice need to be in the conversation? What's impacting our communities? And then how can we work with our coalition partners to make sure that that work gets spread to the voices that need, or to the folks that need to hear that for our policymaking. So I want to talk today about the 340B program, and I also want to talk about pharmacy benefit managers. When we talk about cost for healthcare, these are two places that we see that really need some guardrails and some work around them to make sure that folks are getting access to the support that's available to them. The 340B program is a program that was instituted in the 90s, and it was to make sure that hospitals, particularly that work in lower income or in community, are able to get access to medications that they can then provide to their low-income, the folks that they provide low-income service to at a lower price, to make sure that it's affordable and accessible to everyone. You know, a lot of times we have conversations in Washington about accessibility, but we're not actually getting to the heart of the conversation, because we always find a gap there in what's available and what's accessible. So when we talk about accessibility, we're talking about, is it really affordable? Can folks really get it on the ground? Just because it's available doesn't mean it's accessible. And the 340B program was intended to make medications both available and accessible financially. And it has done that in some regards. But the idea with the savings on the 340B program for the hospital systems was that then they would be able to reinvest in more care, expanded care, more access, and for folks in actual need. And this hasn't really happened in practice. What we're seeing are things like, if it's a big community hospital system, they may take the savings that they get from the 340B program, and yes, the savings are passed along to folks in community. However, the savings that the hospital gets, they're not necessarily reinvesting them into community. They may into the community that needs it the most. They may be reinvesting it into one of their premier areas. So for example, if you have a low-income neighborhood with Black and brown folks who use that hospital regularly, and they may be able to get their prescriptions there at a lower cost, at an accessible cost. But the savings that the hospital system gets, they may be investing that into, say, you know, a maternal health care ward in a higher income neighborhood, so that they can attract more, you know, higher paying, higher insured groups. So really the trickle down into the community isn't happening exactly the way we want, because it was intended, one, for the accessibility, but two, for the reinvestment in community. And so when we talk about policy making, what we want is to put some guardrails around what happens when you have those savings in low-income communities, and then how's that money reinvested. So that's one space where, you know, all these things have to go hand in hand. As advocates, we always think that, well, I think maybe the general public thinks that once we get a big piece of legislation across the line, and, you know, over the last couple of years, big legislation with big investments for community have gotten across the line. But our job really doesn't stop there. Our job is to then say, okay, is this really getting to the intended community that we want? And so that's the next step of it. And that's where the 340B conversation comes in. How do we get the intended funds reinvested to community in the way that's really going to be beneficial for the long term, so that these hospitals and community health centers can really provide some of that preventative care, ongoing care, long-term care that we really need for folks to have throughout their lifetimes, and particularly as they age. Because from Mana's perspective, health is one part of it. The other piece is the financial piece, right? 1 in 5 Latinas over the age of 65 live in poverty. One of the things that folks are unable to or don't think about as they're planning for retirement is the cost of their medications as they retire. And we all know once you retire, it's very difficult to go back and start to make more money or find another job or get back into the workforce to make up some of those gaps. And so really, as we're thinking about the systems that we have, we need to make sure that those systems are taking care of folks through their entire lives, particularly our aging community. The other thing I wanted to talk about are pharmacy benefit managers. I think that the pharmaceutical industry is thought of as an uncaring industry, but the truth is that they have systems in place to make sure that lower cost benefits are provided for those in most need, right? And so that their products can be made affordable to folks who don't have the means to buy them or don't have the insurance to buy them. And what's happening is that there's sort of a middle place, right? Where pharmaceutical companies need to go to market and need to be put in places where pharmacies where everyone goes to get their prescriptions, right? But the middleman, the pharmacy benefit managers, are the folks who are supposed to take those incentives and those things that are supposed to be made available to folks in most need to cut a deal to sell the products to the pharmacies. These folks in the middle, the pharmacy benefit managers, PBMs, you might have heard a lot about them. Their profits are skyrocketing and increasing because they're selling the product to the pharmacies, but taking the largest cut for themselves. And so, when we talk about policymaking, we need to talk about what those guardrails are, because if there are rebates, incentives, philanthropy type programs so that folks in the most need can get access to the medications, we need to make sure that the guardrails are in place so that, raters can't come into the middle of that process and take the money for themselves. And so, when I think of policymaking and immediate places where folks could have relief on their pocketbooks, particularly as, we're seeing, things cost more, the cost of living goes up incrementally. These are places where we could make an immediate impact on folks' pocketbooks and give them some relief, especially when they need it, and especially as they age and need just a little bit more help. And we need to be thinking about that from a policy standpoint. So pharmacy benefit managers, reforming the 340B program to make sure that the funds that are intended for the folks who need it the most are actually received by the folks who need it. And so this is where our efforts remain. Obviously, the preventative care aspect, you've heard a little bit about obesity care and some of those things where, again, when it's intended for community and the guardrails are in place to make sure that the folks in most need are getting what they need to live healthy lives, then that's where we want to be, and that's where we want to be in the conversation, and that's where we want to direct policymakers to make sure that they understand the implications for people who need it the most on the ground. And so I'll turn it back to you, Oscar.
Thank you very much, Ms. Hinijosa. And I think I was able to correct myself and say Mana. Mana was here in Washington, D.C. last week, so I had that in my head. Sorry about that. It's a fact that the Hispanic population continues to grow at a rapid rate throughout the United States. According to a 2017 report from the Agency for Healthcare Research and Quality, Latinos experience more barriers when attempting to seek healthcare than non-Latino whites, despite access to care being recognized as a policy concern. Moreover, disparities in access to primary care services, such as preventative care, have been shown to contribute to concentration of health disadvantages among Latinos and other white racial ethnic groups. But let's hear from our next speaker, also someone I've known for a while, Ms. Rosa Mendoza, the founder, president, and CEO of Avanza. It is her vision, experience, and knowledge of underserved communities that give birth to the organization and set the tone for the organization's critical mission of ensuring Latinos and other underserved communities have an equal opportunity for success in our technology-driven world. Rosa's own experience as a first-generation college student excited her passion and gives her the insight to advocate for this equal opportunity. Today, Ms. Mendoza will speak about innovation in healthcare and its role in addressing health disparities impacting Latinos. Welcome, Ms. Mendoza.
Good morning, everyone. Great to see you, Oscar, and thank you, Dr. Cruz and the NHCOA team for inviting me to be a part of this important conversation. I Emerging technology offers unlimited possibilities for improving our health and enriching our personal and professional lives. One of the most important benefits of innovation and emerging technology is in the area of digital health. Since most severe chronic health challenges disproportionately affect minority and low-income populations, it is crucial that Latinos are able to use telehealth as long-distance virtual health care and have access to patient and professional health-related educational resources. Equally important is the evolution of technology that provides for digital diagnosis and rapid testing to improve health outcomes and greatly benefit disadvantaged groups. Rapid innovation, for example, is allowing doctors and hospitals to provide unprecedented levels of care. For these reasons and more, Alvanza advocates for policies that support the continued evolution of emerging technology for the betterment of our society. Can you change this to the second slide, please? In the next slide, I'm going to share information about the lessons learned from the COVID response, information about pervasive health challenges facing Latino communities, and information about healthcare access challenges facing Latino communities. So what is the challenge, or one of the challenges, right? Well, during the pandemic, most Latinos, regardless of age, died from COVID at a rate almost twice that of the country's white population, for example. And what is the solution? Well, one of the solutions is that the vaccine innovation prevented additional hospitalizations and deaths among all communities. The Commonwealth Fund found that the COVID-19 vaccination program in the US prevented more than 18.5 million additional hospitalizations and 3.2 million additional deaths. Without vaccination, there would have been, nearly 120 million more COVID-19 infections. To address the COVID-19 pandemic, we witnessed a rapid mobilization of the life science companies working around the clock to develop diagnostics, medical devices, and therapeutics. This unprecedented commitment and pooling of resources by the life sciences industry to develop, manufacture, and distribute billions of vaccine doses globally was only possible because of our nation's innovation ecosystem. Now, why do we have a strong innovation ecosystem? Well, that is because America's robust innovation ecosystem is built upon strong patent and IP protections. America's IP system allows innovation to flourish, and it is critical to improving medical treatments and patient care, and it is spurring economic growth. Without adequate IP protection, innovators are unable to secure the needed resources to bring treatments to patients who need them the most. Patents are especially important for incentivizing medical breakthroughs in the biopharmaceutical industry. Patents are an essential incentive to innovation and encourage companies to make the needed investments to develop new treatments and potential cures that are vitally important to patients. Patents are particularly important to the biopharmaceutical industry because only 12% of the new treatments that make it to clinical trials are actually approved by the FDA for use. Can you change it to the next slide, please? So what are some of the pervasive health challenges facing the Latino communities? Well, for example, Latino adults are 80% more likely than non-Latino white adults to be diagnosed with diabetes by a physician. And Latino children are 5 times more likely to be diagnosed than non-whites, than non-Latinos, Latinos are 1.5 times more likely to have kidney failure compared to other Americans. And nearly 1 in 4 Latinos has high blood pressure, which can be a precursor to a heart attack, a stroke, kidney disease, and heart failure. We clearly have a big challenge. And a key part of the solution is innovation in communication and technology in order to increase Latinos' chance of better health. And we saw that the COVID-19 pandemic accelerated telemedicine's adoption, and the federal legislation should continue to expand and extend telehealth services to behavioral health, telemedicine services, and to all communities, including rural communities. Telehealth technology provides comfort and convenience, can control the peak of infectious illnesses, improve mental health assessments and counseling, and save time. It saves time, and improves access for individuals looking to connect with a doctor or a nurse practitioner. I'm clearly having a hard time with that word today. To be inclusive for Latinos, telehealth should provide comprehensive access via smartphones, because we know that Latinos over-index in the use of smartphones, to bridge the racial ethnic differences in computer ownership. The digital divide, which is an issue that Alvanza heavily focuses on, also needs to be addressed to improve access to healthcare. We also need to address raising healthcare costs that are preventing patients from getting the treatments and medicines they need. And one way to do so, is by addressing the practices of pharmacy benefit managers, PBMs, in the healthcare marketplace. 3 PBMs control 80% of the prescription drug market. 3. Insurance companies are using these middlemen to decide what medicines individuals can receive and what they will pay for them out of pocket. Increased transparency and accountability around PBM pricing practices can help promote competition and ensure the patients are receiving the life-saving cures so many innovators and entrepreneurs are working to deliver around the country. Congress should encourage fair and transparent PBM practices to benefit our country's patients. Can you go to the next slide, please? Now let's talk about healthcare access challenges facing Latino communities. Here's one of the challenges. The uninsured rate among Latinos is more than double that among non-Latinos, whites, for example. Even though Latinos are more likely to be in the workforce than non-Latinos, they are less likely to receive health insurance through their employment and are more likely to enroll in Medicaid coverage, for example. Part of the solution is that we believe states should preserve the Medicaid coverage as the pandemic ends. And states that have not done yet, that have not expanded Medicare, should do so. According to the Urban Institute, nearly 18 million people are set to lose Medicaid in the next coming months as the COVID-19 pandemic officially ends. And the HHS projects that around 7 million of those individuals are likely going to lose Medicaid coverage despite being eligible. Due to procedural reasons caused by administrative barriers, such as long wait times, multiple unnecessary requests for paperwork, ineligible people losing coverage at renewal and having to reapply, which disproportionately affects underserved communities, who are more likely to receive coverage through Medicaid, due in large part to the structural inequalities resulting in their overrepresentation in low-paid jobs, lacking employer-sponsored health coverage. Medicaid should be strengthened by the adoption of technology-enabled solutions. Medicaid agencies can support adoption of technology-enabled solutions to advance goals of improving access to care, health quality, and equity. Specific policy approaches may depend on how prescriptive states want to be and incentivize technology uptake, and the specific types of technologies states seek to scale. And lastly, I know Christine is already there, I'm sure telling me that I need to stop. So I will just mention one more point. Additional opportunities to improve access to care include reforming the 340B drug pricing program. Currently, and very much unfortunately, hospitals are abusing the 340B drug pricing program that was meant to support poor, uninsured, and underserved patients. And here's how that's happening. Hospitals are purchasing vast quantities of discounted medicines and reselling them at a big markup to fully insured, affluent patients and communities. Since the law does not explicitly require hospitals to reinvest their savings into underserved communities, they are simply deciding to pocket the difference. These practices are obviously very concerning because they undermine low-income patients' ability to receive quality care. And actually, a study in the New England Journal of Medicine found, and I quote, "Financial gains for hospitals from the 340B program have not been associated with clear evidence of expanded care or lower mortality among low-income patients." And I will stop there and hand over the mic to Christine. Thank you so much for having me.
Thank you, Rosa, for your great presentation. So, Oscar had to leave a little bit earlier, but I will continue on his behalf. I'm Christina Perez. I'm the Director of Programs at the National Hispanic Council on Aging, or NHCOA for short. So before continuing with our next topic, we want to know your opinion. So our second poll question is, what do you think that are the biggest challenges in Alzheimer's disease care? Again, we will provide a minute for you to choose, and please note that you can write other options in the chat box if applicable. Again, the question is, what are the biggest challenges in Alzheimer's disease care? So I think we will be able to see the responses in a minute or so. Oh, there they are. So most of the attendees mentioned that one of the biggest challenges in Alzheimer's disease care is the act.
People of color want healthcare providers who understand their unique experiences and backgrounds, but many doubt that they will have access to culturally competent providers. People of color want healthcare providers who understand their unique experiences and backgrounds, but many doubt that they will have access to culturally competent providers. And knowledge, awareness, concern, and stigma about Alzheimer's just varies very widely across racial and ethnic groups, with Black Americans, especially lacking trust in research clinical trials and doubting that advances in treatments will be shared with other communities. Hispanic, Black, and Asian American dementia caregivers also indicate greater care demands, less outside of help, and greater depression compared to white American caregivers. And this is because we tend to take care of our own in our own homes, and we tend to not talk about Alzheimer's and dementia and how it affects our families. We tend to keep that very close to our hearts. We take care of abuelita and abuelito, but we need to start talking about it more because it affects so many more people around you. Not only does it have an impact on your immediate family, it has an impact on the workforce as well. With greater care demands, people have to call out of work in order to care for their loved one. Doctor's appointments and everything that goes along with the difficulty of a diagnosis of Alzheimer's and dementia. Additionally, we know that there is severe lack of representation in clinical trials. Underrepresented and underserved communities are disproportionately impacted by Alzheimer's and dementia, yet we are less likely to be diagnosed, less likely to be recruited to participate in research, and less likely to have access to care and support services. As a result, scientific advancements and treatments are not designed with us in mind. To illustrate that, there's a significant need in representation in clinical trials. Out of all of the clinical trial participants for Alzheimer's disease drugs, only 5.6% of those participants are Hispanic Latino. Out of all of the clinical trials that have to do with Alzheimer's disease drugs taking place all over the world, only 5% are representative of our community. So we need to change that. So we know that health equity is achieved when every person has the opportunity to attain their full health potential. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstance. So the Alzheimer's Association is calling for efforts to improve this current challenge that we have. We are wanting to prepare the healthcare workforce to care for a racially and ethnically diverse population of older adults. We are advocating for the increase of diversity in dementia care. And we are engaging, recruiting, and wanting to retain diverse populations in Alzheimer's research and clinical trials. So what is the Alzheimer's Association doing to be able to attain this? Well, we are working on several initiatives. You may have heard of the ENACT Act. This is the Equity in Neuroscience and Clinical Trials Act. This legislation was introduced to increase clinical trial participation among underrepresented populations. We're also listening to the community. We've held over 500 listening sessions in the last 3 years with almost 15,000 attendees. And so we're listening to the community and their needs. And lastly, we are focusing on health equity. We now have 2 FDA-approved drugs that can slow down the progression of Alzheimer's disease. The first time in over 20+ years, we have 2 FDA-approved drugs. But we don't have access to these drugs, at least not the entire community does not have access, because the Centers for Medicaid and Medicare Services is blocking access to this treatment by not providing coverage. It is the first time and the first disease to be excluded from receiving coverage. So unless people are able to pay out of pocket for these treatments, they won't be able to get to them. And so this is a big problem, and this is something that we're really focusing on. The CMS decision to continue to deny coverage of FDA-approved Alzheimer's treatments in this class under the accelerated approval pathway is appalling. And we, the Alzheimer's Association and our advocacy arm, AIM, we are working hard to advocate to change the course of this. Early access to FDA-approved disease-modifying therapies is crucial because we know that each day people are advancing to a different stage of the disease in which they're no longer eligible for these treatments will no longer work. So the longer we take to get these crucial treatments covered by CMS, more people are unable to reach these treatments. The CMS policy is unprecedented and it must be reversed. There is growing consensus in the scientific and medical communities about the clinical benefits of thorough removal of amyloid from the brain for people living with mild cognitive impairment and early stage Alzheimer's disease. And since CMS issued its coverage decision last year, new clinical data has been published that clearly demonstrates meaningful clinical benefit from these new treatments, especially lecanemab, which is the newest drug available. In summary, we know that our facts and figures report shines a bright light on barriers facing non-white racial ethnic population in accessing dementia care. That we know that discrimination and lack of diversity in the healthcare profession are significant barriers that demand attention. We know that already this devastating burden of Alzheimer's must not be made worse by discrimination and health inequities in the current system. I hope you're listening, CMS. And the Alzheimer's Association is committed to reducing health inequities and healthcare disparities, particularly as they impact older adults in their ability to access high-quality dementia care. Thank you, Christine. Thank you, Dr. Cruz and NHCOA for having me today. Thank you so much.
Thank you, Darisa. So let's continue with our next presentation. So another chronic disease impacting Latinos is obesity. People with obesity continue to face a social stigma, and the perception that obesity is a lifestyle issue is widespread. Hispanic Americans experience higher rates of chronic disease, including obesity. Hispanic Americans were 1.2 times more likely to have obesity than non-Hispanic whites. Obesity is a treatable disease through behavioral therapy, bariatric surgery, and now pharmacotherapy. Due to the outdated regulations, Medicare does not provide access to the full continuum of obesity care available to patients. But let's hear more from Nancy Glick, who joined the staff of the National Consumers League as Director of Food and Nutrition Policy after a long career in health and nutrition communications, advocacy, and public policy. So today, Ms. Glick will speak about access to obesity treatments. Welcome, Ms. Glick.
Thank you very much. I want to go quickly because I know we're a little late on some of the agenda. So if you go to the next slide, I wanted to start. Next one, please. I wanted to go and give you just a numbers of what obesity means as a public health threat. And as you can see here, literally 3/4 of adult Americans have overweight, and over 40% have obesity. And over 9% have what we call severe obesity, which means, that is sort of a very significant medical condition at that point. People at that BMI usually have about 100 excess pounds. I also put some statistics here because there are significant disparities in obesity. Obesity impacts more older adults, which is what we're talking about here, but it also impacts more Hispanic adults. And when you factor in the fact that everybody over 60 has higher risk of chronic disease, 80% of older adults have 2 or more chronic conditions, and the underlying risk factor for all of these conditions, over 230, is obesity. So we have a major issue here that we need to solve, and unfortunately, nothing seems to be going in the right direction for us. So if you go to the next slide. I'm going to give you a little primer on obesity. First of all, very important, please understand this. Obesity is not a lifestyle issue. It is a serious chronic disease. Who says so? Literally everybody, but the most important is the AMA. We're talking about, the organization of all medical doctors who say that obesity is a disease state with multiple pathology, and it requires a range of interventions. In other words, we have to be serious about diagnosing it and treating it. So there are different categories of overweight and obesity where treatment is essential. And this slide sort of indicates that when you are considered overweight, you are at increased risk, and there are certain recommendations for you. Then there are different stages of what we call obesity. And you can see that the more weight, the higher your risk factor. So I'm going to show you sort of where this excess weight sort of addresses obesity. And there are what we call now 3 pillars of evidence-based treatments. The first is what we call intensive behavioral therapy. And this starts literally at overweight and is important through obesity and severe obesity, because this is where we have interventions that help people get better nutrition, physical activity, understanding really behavior modification. And it's not a online program. It is really intensive, involving health professionals. Then we have what we call anti-obesity medicines, and these are very important. They are new drugs. They have been approved by the FDA, and they do important things because they affect the appetite signaling in the brain, and they have proven to be very effective. And depending upon your stage of severity of obesity, when you have the highest risk, bariatric surgery is a very effective solution. And today there are a lot of new laparoscopic forms, so that it is safe, effective, people really respond. So these three pillars are what we call the continuum of care, the essential things that are needed. And what I put here on the slide is, you know, why we need to all be advocates for treatment, because the improvements of obesity treatment work. And even at less than 5% of a weight loss, you see significant benefits in less hypertension, less blood cholesterol. And you can see as you move along that at a certain percentage, literally people who have what they call pre-diabetes no longer have it. So what we have here are clinical benefits where the disease states that people have, whether it's heart disease, osteoarthritis, liver disease, all of these improve if we are able to achieve a weight loss. And the greater the weight loss, the greater the benefit in terms of health outcomes. So if you go to the next slide, please. So obesity treatment guidelines, and there are many, many, many of them, because obesity is connected to 230 plus chronic diseases. It's what they call a comorbidity. And a comorbidity means that it is the disease worsens with the extent of obesity, and conversely, the disease becomes less problematic with treatment and a lower level of obesity. So, as I said before, there are different levels of obesity, and the treatment paradigm is based on your levels. So at the lowest level, if you see on this chart, we're talking about self-directed lifestyle change. And it's very effective if you have overweight. When you get into a greater degree of, now you are diagnosed as having obesity, it is a combination of drug therapy and lifestyle change. And there are many studies that show that this is very effective. It works well. People's health improves, and chronic disease rates and the outcomes improve significantly. Please remember that, because if we can conquer obesity, we can conquer chronic disease, seriously. And at the highest level, where we're talking about a very significant level of obesity, and that is 40 is what they call severe obesity. But when you have a chronic disease and you have overweight, you can get treatment at a lower level of BMI. So at the higher level, we're talking about weight loss surgery combined with lifestyle change. So that is how the obesity is supposed to be treated. Now let's go to the next slide. Okay. This is what has my hair on fire. I hope it has yours too. So today, about 108 million adults have obesity. That's the 42% of the American population. Now remember that when we talk about people who are Latinos, other ethnic minorities, the numbers with obesity are higher than this general number. Of this 108, only 30 million people, that's about 10% of the public, has been diagnosed at all with obesity. That means they've been told they have obesity and they have been counseled by their docs. And I see that I need to move fast. The other terrible number is that only 2% are getting treated with AOMs. There are a number of barriers. I won't go through them all. They're here. Hopefully we can share this. But the one that we need to talk about is Medicare. Like Alzheimer's disease. This is a condition that should be covered by Medicare, and it isn't. And the reason it isn't, and this is part D now for drugs, is because of an outdated rule that went into effect long before these drugs were even available. And it is preventing people from getting life-saving care, and it is a national disgrace. Part B, which is the other, limits access to those in the IBT, and that is also a problem that we need to address. We also know that under the ACA plans, a number of them, these are the health exchanges, don't include obesity treatment, so that's another issue. So let's go to this last slide, which is what should we be doing about it? First of all, there is a bill. It is the 10th time or the 11th time we've tried to get the Treat and Reduce Obesity Act passed. It's called TROA. It's bipartisan. It is meant to cover both Part D and Part B under Medicare, and to address these particular issues that I talked about, which is that people who are eligible for Medicare, and that's pretty much everybody 65 and above, our audience, are not getting these treatments, and therefore TROA is a priority. We should pass it. The other is that CMS could itself solve this problem by issuing new rules that cover anti-obesity drugs. We've been trying for years to get that done. We're still talking, and CMS really needs to step up and do this. And the final thing is that CMS should also issue final guidance, formal guidance to the states regarding the ACA exchange plans. Because right now, it's up to the states to decide what to cover, and obesity coverage is so important that we really need CMS to demand that states cover this under their exchange plans. And that, in a nutshell, is the story of obesity.
Thank you so much, Ms. Blake. So following the topic of the last presentation, let's welcome Dorothea Vafiadis. Ms. Vafiadis is the Director of Healthy Aging Partnerships and Strategic Engagement at the National Council on Aging, or NHCOA for short, where she develops business alliances to drive wellness initiatives through strategic priorities, programs, and policies. Today, Ms. Vafiadis will provide an overview about the Patient Bill of Rights for overweight and obese people. Welcome, Ms. Vafiadis.
Thank you so much, and thank you, Dr. Cruz and Ms. Perez and the NHCOA team for the invitation. It's a privilege to be here. As a brief introduction to the National Council on Aging, our organization has been building bridges for change alongside generations of families for more than 70 years to ensure their economic health and social well-being. We are the national voice for older adults and those who serve them, and we have worked in partnership with the Aging Network, a collaborative of community-based organizations, private sector partners, and other stakeholders to end mandatory retirement, create the Meals on Wheels program, and protect and strengthen Medicare and Medicaid. And we advocate for community services under the Older Americans Act. Next slide. NCOA's strength is its ability to convene groups with mutual goals and work on systems change. And recently, we brought together stakeholders from 12 organizations, including NHCOA and members of the Diverse Elders Coalition, for a roundtable discussion focused on tackling the chronic disease, obesity, and addressing challenges facing older adults and barriers to receiving quality care. As Nancy mentioned, obesity is a major barrier to healthy aging for millions of Americans aged 60 and over, and a number of challenges impede older adults with obesity from accessing the full range of prevention and treatment options. So at the roundtable that I mentioned, we spent time diving into the issues and discussing the disproportionate impact that obesity has on people of color. And the roundtable findings focused on challenges and solutions. And you can see on this slide, I've listed some of the 10 drivers of inequity that were identified to give you a sense of the issues. A corresponding set of policy solutions were also brought forward. But you can see unrecognized complexity, older adult heterogeneity. Not all older adults are the same. Impact of weight bias and stigma, the devaluation of a person because of their size, lack of integration of healthcare, consequences of discrimination, and limited access to healthcare and treatment, which Nancy covered so well. The proceedings were published in the Journal of the American Geriatric Society. Next slide. So given our learnings and insights from those convenings, the National Council on Aging and the National Consumers League are partnering today to explore these barriers further. We have commissioned a series of 4 town halls across the country at senior centers and community-based organizations to create community dialogues. We'll be having these in locations such as Oklahoma City, Los Angeles, California, Wilmington, Delaware, and possibly Jackson, Mississippi, or New Orleans, Louisiana. We're still figuring out the best location. But as you can see, it's a breadth across the country. Each town hall will include 3 parts: a panel discussion with older adults living with overweight and obesity, a panel discussion with healthcare professionals, and this may include professionals such as nurses, community health workers, doctors, physical therapists, or others who care for patients living with obesity, and a broad conversation about obesity with older adults, civic leaders, and community members. Next slide, please. So findings for this discussion, for these discussions at these town halls, will be integrated, and trends across the regions will be documented and used to develop a patient bill of rights for obesity. What all people living with obesity deserve for themselves, their community, and their healthcare system to manage this disease. Later this fall, we'll have a draft of the Bill of Rights ready for a review panel to provide any additional information that we may be missing. And then NCL and NCOA will release and promote the final Bill of Rights with a call to action for promoting access to evidence-based care, healthcare access, and improving quality of life for those older adults living with overweight and obesity. So as you can see from this schematic, it's a high-level overview of what will be discussed at these panels during the roundtables. So for example, questions like, what limitations does living with excess weight on your quality of life have? What can providers and insurers do so more older adults with obesity are treated with dignity and respect? What are the barriers in your community to access healthcare and quality treatment? What types of information do you need and want to understand your healthcare options? So as part of this effort, we're advocating for coverage for the full range of treatment and accessibility by CMS covering reimbursement by Medicare Part D. And we look forward to sharing the final Bill of Rights with a call to action for promoting access to evidence-based care, healthcare access, and improving quality of life for those living with overweight and obesity. Thank you so much.
Thank you, Dorothea.
My pleasure.
So let's pause for a bit and let's take our next poll question that is titled as, what do you think that are the main barriers in managing obesity? Again, we will provide a minute or so for the attendees to choose the options. And also note that you can write in other options in the chat box. So we are going very fast because we are heading for other presentations. So we will have it available to poll like for a few seconds. Okay. So I'll explain of the responses. Many people indicated all of the above. That will be lack of access to medications, the lack of information, the stigma, indeed, of what our last two presenters just mentioned. So let's continue with the presentation, with other presentations. So we all need vaccines throughout our lives. Vaccination is one of the most convenient and safest preventive care measures available, as we have seen with the COVID-19 vaccines. We must consider that protection from some childhood vaccines can wear off over time. So that's why all adults need immunizations to help them prevent getting and spreading serious diseases that could result in poor health, missing work, extensive medical bills, not being able to care for family. So today I will provide an overview about adult vaccination, particularly with an emphasis on Hispanics and Latinos. So as part of this first slide, when it comes to vaccines, it's important to keep in mind that immunizations, as I just mentioned earlier, are not just for kids. We all need vaccines throughout our life. So that's why it's very important for people to know what vaccines they may need, where they are administered, where can they find it, and receive encouragement from their trusted healthcare providers and loved ones to get vaccinated. So for example, all adults need a seasonal flu vaccine every year. And with seniors, they need to receive the shingles vaccine and pneumococcal vaccine, among other vaccines too. The next slide, according to the Office of Minority Health, well, vaccination rates are lower for Latinos than non-Hispanic whites. And particularly Latinos were 30% less likely to have received the influenza vaccine. And specifically, Latino older adults were 40% less likely to have ever received the pneumonia vaccine when compared to non-Hispanic whites. The next slide, also studies have shown a very strong evidence that spoken language preference, it is an important factor for people to receive the immunizations or not. So again, one study examined predictors of vaccine safety and confidence among Latinas, and such as the education, the healthcare coverage, acculturation, even the religion, were predictors of getting the influenza or not. So when talking about the challenges based on our work, some of the common factors that contribute to disparities in vaccine uptake continues to be, first one, the misinformation or the fake news that our community still encounters on social media platforms, like it happens with Facebook or WhatsApp. Also the digital divide that has historically impacted our community. For example, some people don't have access to the internet. Some seniors don't have a smartphone or a laptop. And a clear example is at the beginning of the vaccine rollout, most seniors needed help in scheduling an appointment via an online platform, and they needed help to schedule an appointment. And therefore, for also navigating that platform was not so user-friendly to navigate, not for seniors, but also for everyone too. And another challenge is the lack of transportation to get vaccinated in a vaccination center. Also the lack of healthcare insurance. Now that the Public Health Emergency 319 declaration ends on May 11th, people without a health insurance will need to pay when getting the COVID-19 vaccines. Also, we have the immigration status that limited people in going to vaccination center and get vaccinated overall. And also we have myths about COVID-19 vaccines and also the mistrust in vaccines overall. And here I want to mention that there's doubt about the vaccine effectiveness. And however, at the National Hispanic Council on Aging, we are using the CDC as a trustworthy source to educate our community about vaccines overall. And so in the next slide, we also have our Let's Get Vaccinated program. And at NHCOA, we have been working to increase adult vaccination among Latinos, and we continue to develop and implement effective culturally and also linguistically appropriate health communications and community engagement strategies. And this is with an effort to increase vaccine confidence, acceptance, and utilization among Latino adults, including seniors. For example, we are developing educational materials about the importance of seniors to get vaccinated against the flu, the COVID, shingles, pneumonia, among many others, and also working along with policymakers to let them know about the challenges the seniors are facing when accessing vaccines. So as part of when talking about successes, well, at the National Hispanic Council on Aging, we are conducting a social connector program and that connects Latino older adults with essential health and social services at Washington, D.C. And as part of our services that we are providing in the Social Connector program, we provide seniors with transportation. We have bilingual staff that can assist as interpreters. We are assisting seniors in enrolling in SNAP, or nutritional enrollment, also scheduling them appointments with their healthcare providers, providing COVID-19 vaccine assistance, among many others. And also we aim at getting as many unvaccinated people as we can to actually get vaccinated, and to help get vaccines to the populations that needs them the most. We continue running our multilingual resource center that is assisting Hispanic communities and older adults to get vaccinated. We are also working with promotoras de salud or community health workers to disseminate educational flyers and education overall about the importance of getting vaccinated. Please note that promotoras de salud are trusted messengers from their communities that meets people where they are and also know best their community's needs. We have been conducting health fairs at Casa Iris, it's our housing facility at Washington, D.C., where we provide a safe place for seniors and their caregivers to receive vaccines. And for example, like the flu, the COVID-19, and this is a space for also seniors to connect with local services like Zumba, music, and much more. And we are currently, as many people are doing, using our social media platforms. And most of the positive aspect in working virtually is that it has allowed us to expand our audiences, talking about our work and beyond borders, right? And making an impact in the virtual setting. And this we do it by informing and improving the lives of Hispanic seniors in their communities and also nationwide. And in conclusion, vaccines do save lives. It lowers your chance of getting sick. Vaccines also lower your chance of spreading certain diseases. And again, vaccines are the safest ways to protect your health and also from your community. And here it ends my presentation. So I'm going to continue. And as part of this legislative breakfast, we want to also provide a testimonial about the challenges and realities of Latinos when accessing healthcare and social services in the United States. So let's welcome a testimonial from Josefina Mata, that she is the Executive Director of Concilio CTS Inc., in a private, a not-for-profit private organization in New Mexico, and with program confidence statewide. Ms. Mata has experience working with underserved populations and has focused on various national and transnational initiatives. So welcome, Josefina.
Thank you, Christine. Buenos días a todos. First, I would like to thank Dr. Yanira Cruz and the NHCOA team for hosting this event, and to thank all of you in attendance for this wonderful event, as it is crucial for all of us to come together to continue working towards helping the communities we serve, and in particular, our Latino communities. It is our hope that we together find solutions to rebuild our communities as we look beyond the end of the public health emergency. The challenges that we have faced, many may not look the same from one community to the next, but resilience is the common denominator to describe how our Latino communities have responded to this public health crisis. Next slide, please. Before the pandemic, Latino communities faced higher rates of food and economic insecurity, health challenges that are contributed to food deserts or food swamps of unhealthy foods, thus creating challenges to living healthy lifestyles and managing chronic conditions. These challenges then make caregiving difficult for many unpaid family caregivers that have difficulties in accessing resources due to the language barrier, cultural fears, digital divide, rural transportation barriers, and systemic issues that affect the Latino communities in being aware of what they need and what may be available to them, and if they feel comfortable in reaching out to those much needed support systems. Concilio encouraged a wide array of community leaders, promotores, and volunteers to lean towards social networks for support with a strong belief that every individual, no matter the age, has something to give. This has been focusing on reciprocity. Their strong community connections assisted everyone. Many of the flexibilities that were provided to government agencies across the whole of government provided individuals to be supported by resources that allowed for families to access healthy foods, in particular for older adults, through local farms and in locations where they feel comfortable in receiving additional resources, which allowed communities to rise above challenges and actively be part of community solutions. Next slide, please. Therefore, with the end of the public health emergency drawing closer with many resources having already ended or soon to end, Latino families will now be set further back and not to square one, as one of the pandemic has created additional challenges. The resources provided for Latino communities were not government handouts, but rather critical resources that many individuals and community leaders were allowed to harness through local non-for-profits or other individuals to serve their communities in addressing community needs. Research provides that resiliency is the capacity within a system to adapt successfully to challenges, whether those challenges stem from social and behavioral determinants of health, economic insecurity, or other. Individuals that are provided the needed resources are then equipped to build community capacity through resiliency. We are at a crucial point in time to continue to provide much needed resources to combat the magnified challenges in chronic conditions, housing and utility insecurity, economic insecurity, and the growing caregiving crisis, which only creates additional challenges to multi-generational households, minority, older adults, and rural populations. Latino communities face many inequities, but if provided the resources for building resiliency, they may continue to build community capacity and rise above community challenges through intergenerational solutions. To address older adult isolation, the caregiving crisis, childcare, youth mentorship, and mental health challenges that are being experienced across all ages due to the disruption of the pandemic, and be active participants in the rebuilding of their community through resiliency. So at this time, we need to advocate. We need to try everything to rebuild our communities as a best practice is implemented across different sectors, most recently referenced by community solutions across the nation. Next slide. And thank you to all of you for taking the time to hear and share the challenges faced by our Latino population. And again, thank you, Dr. Cruz and the NHCOA team for hosting this critical event. Thank you, Christine.
Thank you, Josephine. So let's continue with our next presenter. So Congress enacted the 340B program as part of the Public Health Service Act more than 30 years ago to enable true safety net providers to help low-income and other vulnerable patients access more affordable medicines and healthcare services. Unfortunately, stronger accountability and transparency are needed urgently to ensure the program can begin to work as intended and patients don't continue to get left behind. But let's hear more about this issue with our next speaker, Mr. Thomas Johnson, the Executive Director of ASAP 340B. A native of Washington, D.C., he brings 30 years of professional experience in the healthcare, nonprofits, and association management space. Today, Mr. Johnson will provide an overview about the 340B Coalition. Welcome, Mr. Johnson.
Thank you, Christine, and thank you, Dr. Cruz, and thank you for having me participate in this breakfast. Just by way of background, a little bit about myself. As stated, I've been in kind of the business for over 30 years. Some of the groups I've represented included running the Medicaid Health Plans of America for 9 years. Also ran the DC Hospital Association and the Population Health Alliance. I've also served in leadership roles with the Gorman Health Group, the Medical Society of the District of Columbia, the Greater Washington Board of Trade, health plan called DC Chartered Health Plan. And I also serve as the current chair of the Board of Directors of the Sickle Cell Disease Association of America. Next slide. So some of the questions I wanted to try and cover: one, what is the purpose of the 340B program? I'm not going to cover that because I think our first panelist did a great job talking about the history and the purpose of the program. But I do want to talk about why are patients not benefiting from the program as intended, why there are lower levels of charity care provided by nonprofit hospitals, mainly of which are 340B, and what meaningful and constructive solutions can be achieved to ensure the 340B program can work for safety net providers and the patients and communities who depend on them. Next slide. So one of the challenges that we have with the program is that every covered entity is not held up to the same standard of how they serve vulnerable populations and underserved patients. While community health centers and safety net clinics reinvest income they get from the 340B program back into patient care as required by federal law, other 340B recipients are allowed to spend their 340B profits in ways that don't benefit patients. For example, University of Miami's UHealth system, which participates in 340B, used revenue from their health system to pay the salary of University of Miami's football coach. And hospitals often engage in practices such as surprise billing and predatory debt collection that hurt vulnerable patients and create significant burdens to them accessing care. And we think it's fair to say that all 340B covered entities should be held to the same standard. Why are there lower levels of charity care provided by nonprofit hospitals, many of whom are in the 340B program? The lack of transparency and accountability in the program means that hospitals that financially benefit from this program have little incentive to offer charity care or make investments in their community. You would expect that any 340B hospital's footprint expands in the community. The amount of charity care should also increase because it's serving Medicaid and uninsured patients that generate high amounts of uncompensated care. But some 340B hospitals register smaller facilities and specialty practices, also known as child sites, in areas with more privately insured patients, so those sites can also qualify for 340B discounts. As a hospital expands their eligibility, they are also often reducing services at the original location, serving vulnerable communities. There was an investigation by the Wall Street Journal that found that the Cleveland Clinic has dozens of sites registered for 340B drug discounts located outside its home neighborhood. almost all located in areas with high rates of private insurance and higher household income than the flagship campus. And a New York Times investigation found that Bon Secours Mercy Health bought Richmond Community Hospital, a 340B hospital located in a community that serves vulnerable patients, and then registered many child sites of Richmond Community Hospital and reinvested the 340B savings to expand services at the sites in wealthier areas while reducing services at the original 340B eligible site. What meaningful constructive solutions can be achieved to ensure the program can work for safety net providers and the patients and communities who depend on them? We feel that stronger accountability and transparency are needed urgently to ensure the right safety net providers are benefiting from the program and their patients don't continue to get left behind. That is why ASAP 340B developed a series of policy proposals, which we will talk about in a few minutes. But if we don't act now to modernize the program, underserved communities will be left with fewer benefits, healthcare options, and a lack of primary care and other services, and overall lower quality of care. Next slide, please. I'm sorry, let's stay on the previous slide. So this is where we are. This is a program that we've created, the coalition that we've created, and we are a coalition of stakeholders that include community health centers, patients, providers, and consumer advocates, as well as leaders from the biopharmaceutical industry who have come together to ensure the 340B program supports true safety net providers and the communities that they serve. Since we launched in mid-March, we have continued to grow, adding new partners. As we continue to grow the alliance, it will reflect the voices of a broad range of safety net providers while strengthening the 340B program. And we are also happy to have the National Hispanic Medical Association, led by Dr. Elena Rios, as part of our coalition. Next slide. So these are our policy principles. And in the interest of time, I want to really kind of point out certain major principles that are underscored, and you can find out more on our website. Those include clarifying the intent of the program to provide resources for true safety net providers to reach the most vulnerable and underserved communities, principle 1. Making sure that prescriptions are offered to patients at a discount, principle 2. Establishing clear criteria for contract pharmacy arrangements, principle 4. Addressing PBMs that are gaming the 340B program by taking rebates from manufacturers and stealing 340B savings from safety net providers, principle 5. Updating and strengthening hospital eligibility requirements, principle 6. And facilitating public reporting and oversight of the program, principles 9 and 10. So in conclusion, I encourage you to visit our website at asap340b.org, where you will find details behind each of the 10 policy principles and an FAQ that was developed based on conversations with members of our coalition. As we move forward, we'll be educating 340B stakeholders and members of Congress about the urgent need to make changes to this program. And thank you for inviting me for this afternoon's meeting.
Thank you, Mr. Johnson. So before ending today's virtual legislative breakfast, let's welcome Mr. Jorge Lambrinos, who's actually the chairman of NHCOA's board of directors. Welcome, Mr. Lambrinos.
Thank you, Christine. And we have now come to the end or close to the end of this wonderful webinar. And I want to take the opportunity now to thank all the participants, especially Bob Blancaro, fellow NHCOA board member and longtime aging advocate, for joining us today in this most important discussion for our community. I also want to thank all the presenters for the excellent information they provided us today. I hope this information will be helpful in formulating and proposing policies to benefit not only the Latino community, but all older persons in need of quality health care. Finally, I want to thank Anita Cruz and her staff for organizing such an important event, especially Christine Perez for making sure I joined the webinar on time from California. The United States is the only industrial democracy that does not provide health care for all of its citizens. The consensus view among health policy experts is that Americans pour enough money into health care, which, by the way, is a thriving 2.6 trillion industry, to have universal coverage. Nationally, 46 million non-elderly individuals were uninsured in 2009. Expanding access to health coverage for many of the uninsured is one of the major goals of the health reform law. People of color have higher uninsured rates than non-Hispanic whites, and Hispanics are the group with the highest uninsured rate at 32%. Were it not for public programs such as Medicaid, uninsured rates for all individuals, regardless of race, would be higher. Having health coverage is an important determinant of access to health care. Fewer uninsured individuals have a usual source of care or receive preventive care screenings compared to insured individuals. The uninsured have more preventable hospitalizations and have worse health outcomes than those with insurance. We still have a long ways to go to provide equity in healthcare to population of colors. Historically, many sectors, including public health and the healthcare system, have not sufficiently addressed health equity and have consciously or unconsciously perpetuated systemic inequities. As we heard today, many people and communities have experienced generations of discrimination and exploitation, creating a continuing structural barrier to improving their health. Although significant strides have been made in the U.S., health inequities persist, resulting in continuing disproportionate impact. People who are women, Black, Hispanic, American Indian, Alaskan Natives, people with intellectual disabilities and other disabilities, and people with lower socioeconomic status and lower educational attainment are disproportionately impacted. Today's legislative breakfast was a wonderful opportunity to bring attention to important health areas that are getting in the way of reaching health equity for Latinos and older adults. In closing, we invite you to follow us on our social media for more information about the work of the National Hispanic Council on Aging to achieve health equity. Thank you very much and enjoy the rest of your day.
Thank you, Mr. Lambrino. So again, we would like to thank all of our attendees, our sponsors, and experts for joining us for today's virtual event. And for more information about upcoming webinars or other in-person events, we encourage you to please visit NHCOA's website and also in our social media platforms, including Twitter, Facebook, Instagram, by using the handle @NHCOA. Until the next one, thank you.